Bismillahirrahmanirrahim. On to the question number 28. So there is a 66 years old man comes to the physician for regular follow-up. He experiences mild fatigue but otherwise has no complaints. Then the patient has a history of hypertension, type 2 diabetes mellitus, hyperlipidemia, chronic kidney disease and ischemic cardiomyopathy. His temperature is 36.7 degrees Celsius, that is 98 degree Fahrenheit. Blood pressure is normal, 122 by 70 millimeters of mercury, and pulse is 82 per minute, that is high. Physical examination shows moist mucous membranes. The temperature is, there is a 2 by 6 hollow systolic murmur at the apex that is unchanged from a previous finding. He has trace bilateral lower extremity edema. The lab results are as follows. The sodium is 135 millicavalients per liter, potassium is high, 6 millicavalients per liter, bicarbonate level is normal, blood urine nitrogen is very high, the creatinine level is also very high, the calcium level is normal-ish, and the glucose level is also high. 2 months ago, his creatinine concentration is 2.3 milligrams per deciliter, and now it is 2.4 milligrams per deciliter. Electrocardiogram shows normal sinus rhythm without other abnormalities. Which of the following is the best next step in the management of this patient? And among the given options, the best option of choice is option E, that is review the current medications. Educational objective of this question is: the most common cause of hyperkalemia includes acute or chronic kidney disease, medications, or disorders impairing the renin-angiotensin axis. Common offending medications include non-selective beta-adrenergic blockers, potassium-sparing diuretics, for example, triamterene, angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, and non-steroidal anti-inflammatory drugs. So, in this table given in the discussion, you can see that common medications that can cause hyperkalemia are as follows. The medication, first one is ACE inhibitors and angiotensin receptor blockers. They decrease the aldosterone secretion, inhibiting the angiotensin II and angiotensin II receptor, and also inhibit the epithelial sodium channels on the collecting tubules, ENaC channels. Then we have cyclosporin, which blocks the aldosterone activity. The digitalis, that inhibits the sodium potassium ATPase so that potassium cannot enter the cells, and that will result in hyperkalemia. The heparin, it blocks the aldosterone production. Okay, this is an odd one. Then we have non-selective beta-adrenergic blockers. It interferes with the beta-2 mediated intracellular potassium uptake. NSAIDs, that decrease the renal perfusion and decrease the potassium delivery to the collecting ducts. Okay, so a side note, if you want to have the PDF, you can go to this channel on Telegram. Then potassium sparing diuretics inhibit the ENaC on the aldosterone receptors. Succinylcholine cause the extracellular leakage of potassium through the acetylcholine receptors. Then we have trimethoprim, that inhibits the ENaCs or epithelial sodium channels. Coming to the discussion, the patient has hyperkalemia, that is potassium more than 5 milliequivalents per liter, which is often due to decreased urinary potassium excretion. The most common etiologies of hyperkalemia are acute or chronic kidney disease and medications or disorders that impair the renin-angiotensin axis. Other etiologies include increased potassium movement out of the cells, for example, uncontrolled hyperglycemia and metabolic acidosis, or increased tissue catabolism, for example, trauma or tumor lysis syndrome. Patient with chronic hyperkalemia may be asymptomatic until the potassium gradually rises to more than equal to 7 milliequivalents per liter. However, acute hyperkalemia can occur symptoms at lower levels. Patient may develop ascending muscle weakness and with flaccid paralysis and electrocardiogram changes, for example, peaked T waves followed by the short QT intervals, QRS widening, and a sine wave with a ventricular fibrillation. Initial evaluation of the hyperkalemia includes ECG to evaluate the conduction abnormalities. Acute therapy, for example, the calcium gluconate, insulin with glucose, is typically reserved for the patient with ECG changes, potassium more than equal to 7 milliequivalents per liter, without characteristic ECG changes, or rapidly rising potassium due to tissue breakdown. However, this patient has a normal ECG and does not require the calcium gluconate. The next step is due to the acute treatable secondary causes, for example, uncontrolled hyperglycemia or tumor lysis syndrome. Patient should then have a review of the recent current medications, as they frequently can cause hyperkalemia. Common offending medications include non-selective beta-adrenergic blockers, potassium-sparing diuretics like triamterene, angiotensin-converting enzyme inhibitors, angiotensin 2 receptor blockers, and non-steroidal anti-inflammatory drugs. The choice B, that was measure the serum renin aldosterone level. We have already seen that serum calcium gluconate was not the option of choice. Option B, measure the serum renin and aldosterone levels. It was not the option of choice because the patient with persistent unexplained hyperkalemia should be evaluated further for hypoaldosteronism with serum renin and aldosterone level. However, this patient should first have a review of his medications. Then the choice Charlie, the choice C, that is obtain the serum ketone levels. It was not the option of choice because uncontrolled hyperglycemia due to insulin deficiency can shift the potassium out of the cells to cause hyperkalemia. However, these patients tend to have significant hyperglycemia, that is more than 300 milligrams per deciliter, and anion gap metabolic acidosis due to ketoacidosis. The patient's absence of low bicarbonate or significant hyperglycemia makes this less likely. The choice delta, that is obtain the urinalysis and urine electrolytes. This is not the option of choice because the urinalysis has limited value for evaluating the hyperkalemia. However, the urine electrolytes can help differentiate renal from the extra-renal causes, of hyperkalemia, and would be indicated if no offending medications are found. The next question, number 29, they are asking about a 45 years old man who comes to the emergency department due to coughing up blood. The patient has had episode of harsh coughing. Okay, so the patient has had episode of harsh coughing uh, this morning, and then noticed streaks of bright red blood in his sputum during the subsequent coughs. The patient has 3 weeks of nasal congestion and progressive cough, which now awakens him from sleep. He has no chronic medical conditions. Vital signs are normal. The patient is well appearing and in no acute distress. The nasal mucosa is boggy and the posterior oropharynx is erythematous. The lungs have few scattered crackles and the heart sounds are normal. The lab studies are as follows. The complete blood count, hemoglobin is normal. The platelet count is also normal. The leukocytes are elevated, 15,200 per millimeter cube. Segmented neutrophils are low. Bands are less. Eosinophils are 2% and the lymphocytes are 78%. The monocytes are 6%. Which of the following is the most likely diagnosis? And the best option among the given choices is pertussis in a 45-year-old man. Educational objective of this question is pertussis often occur in the adolescents and adults. Sorry, it often occurs in the adolescents and adults. In general, it generally manifests as a stepwise illness that begins with 1 to 2 weeks of non-specific symptoms and then progresses to several weeks of classic paroxysmal cough. Adults often do not have the classic post-tussive emesis. Most resolve within 3 months. So the discussion about pertussis is showing us the clinical phase. Firstly, we have catarrhal phase, that is going to last for 1 to 2 weeks. This includes mild cough and rhinitis. Paroxysmal phase of 2 to 6 weeks include the cough with inspiratory whoop, post-tussive emesis, infants and possible apnea. The convalescent stage will show symptom resolve. In the convalescent stage, the symptoms will resolve gradually. The diagnosis is pertussis culture or PCR. Lymphocyte predominant leukocytosis will be there. The diagnosis is made by pertussis culture or PCR, and the lymphocyte predominant leukocytosis is seen. Treatment is with the macrolides. The prevention is acellular pertussis vaccine. This patient's persistent vigorous cough, post-tussive hemoptysis, and peripheral lymphocytosis raises strong suspicion for the infection with a Bordetella pertussis, a highly contagious gram-negative bacterium transmitted by the respiratory droplets. Although young unvaccinated children are at greatest risk for severe disease, approximately 50% of the cases occur in adolescents and adults as well. Bordetella pertussis has tropism for the ciliated epithelium of the upper respiratory tract. Following attachment, the pathogen releases cytotoxins that denude the damaged respiratory epithelium, leading to stepwise illness. Firstly, there will be catarrhal phase, weeks 1 to 2. Symptoms, for example, malaise, cough, conjunctival injection, and excessive lacrimation, which are non-specific, will be seen. The paroxysmal phase, weeks 2 to 8, ciliated epithelium damage cause microaspiration of oral secretions and result in paroxysms of vigorous coughing, often worse at night, wakes the patient from the sleep. The classic presentation of post-tussive emesis is frequently absent in the adults. However, denudation of the respiratory epithelium occasionally leads to hemoptysis after coughing spells. Most patients otherwise feel fairly well. Convalescent phase, weeks 8 to 12, the cough slowly begins to improve. After 3 months, most cases are resolved. Symptoms are less severe in the adolescent and adults, but pertussis should be suspected in the patient with persistent more than 2 weeks of cough and either paroxysmal cough, inspiratory whoop, or post-tussive emesis. Lymphocytosis, toxin induced is often an important diagnostic clue. Confirmation can be made by respiratory culture or PCR testing. The choice A, that is allergic bronchopulmonary aspergillosis, can cause hemolysis, but almost all the cases, the choice A, that was aspergillosis, it is not the option of choice because allergic bronchopulmonary aspergillosis can cause hemolysis, but almost all the cases occur in those with underlying asthma or cystic fibrosis. In addition, eosinophil count, not the lymphocyte count, is generally elevated. The patients also generally have bronchial obstruction, expectoration of the brownish mucus plug, and low-grade fever. The choice B, that is aspiration pneumonia, it was not the option of choice because aspiration pneumonia often causes subacute pulmonary symptoms and can sometimes lead to hemoptysis. However, most cases occur in the patient with a period of altered sensorium, for example, alcoholism, drug abuse, seizure disorder, or swallowing dysfunction. Lymphocytosis and nasal congestion are atypical, and sputum is often foul smelling for the aspiration pneumonia. The choice C, that was influenza, it was not the option of choice because uh, influenza can cause nasal congestion and cough, but it typically also causes fever and myalgias and resolve within 5 to 7 days. Myalgias and resolve within 5 to 7 days. The choice E, that is tuberculosis, it was not the option of choice because in tuberculosis often present with a subacute or chronic cough and can occasionally cause hemoptysis. However, fever and other manifestations, for example anorexia, fatigue, are usually present, and nasal congestion is atypical. The next question is question number 30, and they are asking here about a 45 years old man who comes to the physician for a follow-up after recent emergency department visit for abdominal pain. The pain subsided with analgesics. However, he was found to have elevated blood pressure and an incidental right adrenal mass on abdominal imaging. The patient has no prior abnormal finding. He has no symptoms except mild headache, which he attributes to stress at work. He does not use tobacco, alcohol, or illicit drug. The patient's blood pressure today is 160 by 94 millimeters of mercury. Serum potassium level is 3 millicavalients per liter, that is low. And sodium level is 146 millicavalients per liter, that is a bit higher because the upper cutoff value is 145 millicavalients per liter. Further work of the plasma aldosterone plasma renin activity shows a ratio of 45. He refuses to undergo surgery for the removal of adrenal mass. Which of the following is the best initial therapy for this patient? So the answer of choice is option C, that is eplerenone. Educational objective of this question is primary hyperaldosteronism is usually due to an adrenal adenoma or bilateral adrenal hyperplasia. Surgery is preferred for unilateral adrenal adenoma. Medical therapy with the aldosterone antagonist, for example spironolactone, eplerenone, is recommended for the patient with the bilateral adrenal hyperplasia or with unilateral adrenal adenomas who either refuse surgery or are poor surgical candidates. Now you can see the table which is given in this discussion, the clinical features of primary hyperaldosteronism. So the clinical presentation: hypertension, metabolic alkalosis, hypokalemia, and mild hypernatremia will be there. No significant peripheral edema due to the aldosterone escape mechanism is also seen. The diagnosis: elevated plasma aldosterone, low plasma renin. Plasma aldosterone to plasma renin activity ratio of more than 20 suggests the diagnosis. So it must not be more than 20. The plasma aldosterone to plasma renin activity must not be more than 20. In our patient it was 45. Adrenal suppression testing after oral saline load confirms the diagnosis. Abdominal imaging, for example CT, and adrenal venous sampling to distinguish between the unilateral adrenal abdomen and bilateral adrenal hyperplasia. Unilateral adrenal adenoma and bilateral adrenal hyperplasia. Unilateral adrenal adenoma, the treatment is surgery is preferred. Aldosterone antagonists, for example spironolactone and eplerenone, for the poor surgical candidates or patients who are refusing surgery. And the bilateral adrenal hyperplasia, aldosterone antagonists are given. Okay, then the patient's presentation of hypersecretion, hypokalemia, and computed tomography scan showing an adrenal mass is consistent with the primary hyperaldosteronism. The condition is usually due to an adrenal adenoma or bilateral adrenal hyperplasia. The diagnosis is suggested by elevated plasma aldosterone concentration with a plasma aldosterone to renin ratio of more than 20. The elevated aldosterone leads directly to the decreased renin through a feedback inhibition. Adrenal suppression testing after the oral saline load can confirm the diagnosis. Adrenal imaging with a CT scan and adrenal venous sampling can usually distinguish between the unilateral adrenal adenoma and bilateral adrenal hyperplasia. Surgery is preferred for the unilateral adrenal adenoma. The medical therapy is recommended for the patients with bilateral adrenal hyperplasia or with unilateral adrenal adenomas who refuse surgery or are poor surgical candidates. Spironolactone is an aldosterone antagonist and the preferred initial medical therapy. However, spironolactone is also a progesterone and androgen receptor antagonist that can cause significant side effects in both men, decreased libido and gynecomastia, and women, breast tenderness and menstrual irregularities. Eplerenone is a very selective mineralocorticoid antagonist with a very low affinity for progesterone or androgen receptors. It has fewer endocrine side effects and it is an alternate therapy. The choice A and E, that is chlorthalidone and ramipril, both of them were not the option of choice. Why so? Because the chlorthalidone, some patients still have persistent hypertension despite aldosterone antagonist therapy. Additional antihypertensives such as thiazide diuretics, for example chlorthalidone, or angiotensin converting enzyme inhibitors, for example ramipril, are usually recommended. Okay, usually recommended for blood pressure control in these patients. However, they are not the best initial therapy. The choice B, D, and F. None of them were the option of choice. B, D, F are the clonidine, that is alpha 2 antagonist, D, hydralazine, that is veno and arteriolol. No, that's just arteriololate, I guess. Yes, hydralazine, and then verapamil, that is the calcium channel blocker. None of them were the option of choice because the clonidine, hydralazine, and verapamil are not initially preferred as a medical therapy for primary hypertension. They are second or third line hypertensive that may be used in some patients with persistent hypertension despite adequate first line medical therapy. Then we have the next question, question number 31. They are asking about a 25 years old man is brought to the emergency department due to generalized tonic-clonic seizure. Okay, so there is generalized tonic-clonic seizure. According to his roommate, the patient has had worsening confusion and lethargy for the last 2 weeks. Today he had seizure lasting approximately 3 minutes. The patient has a history of HIV and is not adherent with the antiretroviral therapy or other HIV related medication. He is an active injection drug user. The temperature is 37.7 degrees Celsius or 99.9 degrees Fahrenheit. Blood pressure is 130 by 80 millimeters of mercury. Pulse is 98 per minute and the respirations are 16 per minute. On physical examination, the patient is somnolent but arousable. There is no focal extremity weakness or sensory loss. CD4 count is 26 per millimeter, that is very low, and the viral load is 86,000 copies per ml. MRI of the brain with contrast shows a solitary, irregular, non-homogeneous ring-enhancing lesion in the periventricular area. Cerebrospinal fluid PCR is positive for the Epstein-Barr virus DNA. Which of the following is the most likely diagnosis in the patient? So the answer choice is, among the given options, the best answer is option delta, that is primary CNS lymphoma. So educational objective of this question is, patients with advanced AIDS are at increased risk of malignancy. The primary CNS lymphoma is an AIDS defining malignancy. Associated with the expression of Epstein-Barr virus oncogenes, which can often be identified in the cerebrospinal fluid. MRI of the brain generally shows solitary, irregular, non-homogeneous ring-enhancing mass. Then in this table, AIDS defining malignancies are listed. So Kaposi sarcoma, it is caused by human herpes virus 8. Invasive cervical carcinoma, that is caused by human papilloma virus. Non-Hodgkin lymphoma caused by Epstein-Barr virus. Primary CNS lymphoma is also caused by Epstein-Barr virus. So these are viral virus associated malignancies which are AIDS defining in nature. The patients with untreated AIDS has confusion, seizures and ring enhancing DNA in the brain MRI. Although cerebral toxoplasmosis and bacterial abscess can cause similar manifestations, the presence of Epstein-Barr virus DNA in the cerebrospinal fluid makes primary CNS lymphoma (PCNSL) most likely. Patients with AIDS are at increased risk for malignancy due to impaired immunosurveillance and unchecked expression of the latent viral oncogenes. AIDS defining malignancies are associated with the latent viral infection. Kaposi sarcoma is associated with the human herpes virus 8. Invasive cervical cancer is associated with the human papillomavirus, and non-Hodgkin lymphoma and PCNSL, that is primary CNS lymphoma, are associated with the Epstein-Barr virus. Therefore, evaluation of the viral component is often part of the diagnostic workup for these malignancies. Suspicion of the primary CNS lymphoma is generally raised when a patient with AIDS develops progressive confusion, lethargy, seizures, and focal neurological deficit in the setting of a solitary, irregular, non-homogeneous ring-enhancing lesion on the brain MRI. The diagnosis is generally confirmed by the Epstein-Barr virus. DNA is isolated in the cerebrospinal fluid, especially about 100% of the primary CNS lymphoma cases. The specificity is about 100% for primary CNS lymphoma for the Epstein-Barr virus DNA isolation in the cerebrospinal fluid. The brain biopsy is usually not required. The choice A, that is AIDS dementia complex. So it was not the option of choice because AIDS dementia complex is marked by the cortical and subcortical atrophy and ventricular enlargement on brain imaging. The patients usually have subacute or chronic cognitive deficits, depressive symptoms, and impaired psychomotor ability. The choice B, the choice B, that was bilateral bacterial abscess. It was not the option of choice because the bacterial brain abscess is much less common in the patient with the advanced AIDS than the cerebral toxoplasmosis, or primary CNS lymphoma. Most cases are associated with the signs and symptoms of primary infection and other areas, for example, dental infection. Epstein-Barr virus DNA would not be seen in the cerebrospinal fluid. The choice C, that is over here, the cerebral toxoplasmosis. Cerebral toxoplasmosis is not the case because the cerebral toxoplasmosis is common in the patient with advanced AIDS, CD4 count of less than 50 per millimeter cube. However, multiple ring enhancing lesions are usually present, and Epstein-Barr virus DNA is not seen in the cerebrospinal fluid. The option E, that is over here, the progressive multifocal leukoencephalopathy, it was not the option of choice because progressive multifocal leukoencephalopathy commonly occurs in the patient with advanced AIDS. Uh, Although this type of leukoencephalopathy often presents with a confusion, lethargy, and seizures, brain imaging demonstrate confusion, lethargy, and seizures. The brain imaging demonstrate numerous non-enhancing lesions that do not cause mass effect. In addition, this condition is associated with the reactivation of JC virus, not Epstein-Barr virus. Condition is associated with the reactivation of JC virus, not Epstein-Barr virus. Then the next question, let me see if we can do this. So the next question is about this thing. So they are asking about a 56 years old woman, 56 years old man, I'm sorry, comes to the office due to 1 year history of skin lesions. He has had rough and flaky spots, which do not itch or bleed, and they do not itch. On his forehead and cheeks, the patient has attempted treatment with various emollients without effect. Medical history includes hypertension and early benign prostatic hyperplasia. The patient works as a building inspector and does not use tobacco, alcohol, or illicit drugs. Vital signs are normal. On examination, multiple scattered white scaling lesions are noted as shown below. So these are the lesions like this one, and I guess the other ones are over here. So which of the following is most likely diagnosis in the patient? Actinic keratosis, allergic contact dermatitis, pityriasis rosaceae, psoriasis, seborrheic dermatitis, or seborrheic keratosis. And the answer of choice is option A, that is actinic keratosis. Educational objective of this question states that actinic keratosis is characterized by scaly plaques or papules on the scalp, face, lateral neck, and dorsal surfaces of the hands. Chronic sun exposure is a major risk factor for this. Actinic keratosis can progress to squamous cell carcinoma, but likelihood of malignant progression of an individual lesion is low. So now here you can see in the discussion that the patient has actinic keratosis which present as scaly papules or plaques. Scaly plaques or papules most commonly in the fair-skinned individuals. Chronic sun exposure is a major risk factor and surrounding skin often displays feature of solar damage, for example telangiectasias and hyperpigmentation. Actinic keratosis is found predominantly on the scalp, face, lateral neck and dorsal surfaces of the hand. Its clinical significance is due primarily to the potential progression of squamous cell carcinoma, although the likelihood of malignant progression of an individual lesion is low. Actinic keratosis is diagnosed based on appearance, but biopsy is indicated for the lesion that are more than 1 cm in diameter, have an indurated appearance, exhibit ulceration. They have indurated appearance, they exhibit ulceration, and rapidly growing or fail appropriate treatment. Histopathology shows thickening of the epidermis, acanthosis, retention of the nuclei in the stratum corneum, parakeratosis, nuclear atypia, and abnormal keratinization with thickening of the stratum corneum. Individual lesions can be treated with a focal cryotherapy, for example, liquid nitrogen, but involvement of the large area may require field therapy, for example, fluorouracil. The choice B, that is over here, allergic contact dermatitis, it is not the option of choice because the allergic contact dermatitis is characterized by the erythematous papules or vesicles with the lichenification in chronic cases. Common triggers include toxicodendron plants, for example, poison ivy, nickel rubber, and topical medications. Affected areas are usually very pruritic. The choice C, that is pityriasis versicolor, it is pityriasis rosacea. It is not the option of choice because pityriasis rosacea is characterized by the numerous oval scaly plaques following the cleavage lines of the trunk. It often begins with the initial lesion, that is herald patch, that is much larger than the later lesion. Psoriasis, it is not the option of choice because the psoriasis is characterized by the well circumscribed plaques with silvery scales. It occurs predominantly over the extensor surface, for example, the elbows, knees, and scalp. The choice E, that is seborrheic dermatitis, it is not the option of choice because seborrheic dermatitis causes scaly, oily, erythematous rash affecting the skin folds around the nose, eyebrows, ears, and scalp. Then seborrheic keratosis, option F, that is not the option of choice because it is a benign pigmented lesion and a well demarcated border and a velvety or greasy surface. It is often described as having stuck on appearance. So we'll keep the session till here and we'll continue from the question number 33 in the next session. Until then, Allah Hafiz, fi amanillah, and take care.